Good evening, everyone. On behalf of Neuro-Otological Society of India, I welcome Dr. Carlos Figueroa. He's a very good and dear friend, and we met in the House here Institute. And he is the program director, sub-director of the cochlear implant program in Guatemala City. And he's a par excellent neurologist, and we will be listening to him today about his concept toward BPPV. And when I was there in the House Institute, we used to discuss cases and all that, and he made me understand that a few years back that what is canal ellipsis, what is cupellal ellipsis, and along with his expertise, we have now in our panelists from India, Dr. Sonali Pandit from Mumbai, Dr. Sreeram from Kochi, and Dr. Swaranand Gholap from Pune. So we will be discussing the basics, the concept of the BPVP, and the various maneuvers which we do for BPVP, and then we will discuss all the questions which are there, the panelists and our guest faculty from the Guatemala city. And Carlos is, I think you can share a screen and start your presentation. Thank you very much for being with us.
Okay. So good night in India and a good morning here in Guatemala. In Guatemala, we are 8 o'clock in the morning. First of all, I would like to thank my great friend Amit for this invitation to share with you some concepts that we have learned, and I hope to share with you and this information to be useful for you. And I apologize if my English is not the best. I hope you to apologize for this. Originally, I had this presentation in Spanish, so I tried to translate to the English. And I hope you to be useful this for you. Okay, so I don't have any conflict of interest to declare to give this this talk. So we are going to move to the perspective of the presentation. We are going to talk about a little bit about introduction, review some anatomical physiological points about the posterior, anterior, and lateral canals, diagnostic maneuvers to treat canalo and cupulolithiasis. Really, I think it is to understand why we perform every movement in every maneuver with a helmet that I've been developing in Colombia. Some cases that I would like to share with you, and common questions that usually we have when we talk about BPPV. So we are going to begin saying that it's the most common cause of vertigo in all the ages, from children to elderly, most frequently ages from the 6th to 7th decade of life. The main cause is idiopathic, but everything that irritates the inner ear can cause the BPPV. So trauma, vestibular neuritis, Meniere's disease, everything can lead us to BPPV. So when we find the BPPV, we always have to look if there is another disease down there, okay? And even vestibular migraine can cause BPPV. So in 70%, we will have these cases resolved spontaneously in weeks or months. So the objective is to resolve it earlier. So some very basic concepts are to remember the characteristics of every nystagmus in BPPV. Remember that it has a latency. It always is in a fashion crescendo decrescendo. It fatiguates, I use this here because when we talk about cupulolithiasis, it can last a little bit more. And so before we used to say if it fatiguates, it is peripheral, and if it is lasts more, it is central. But now we know that cupulolithiasis can cause a long period nystagmus. Remember that they follow the Ewell's laws that we are going to talk about a little bit. And always have to remember that the patient must have vertigo when having nystagmus. If the patient has nystagmus but not vertigo, or the sensation of vertigo, that can lead us to think in a possible central lesion. So let's remember some concepts. Here we have the inner ear. Here we have, remember that we have one ampular and one non-ampular side of every canal. In the case of the anterior and the lateral semicircular canals are anterior, and in the case of the posterior canal, it's in the posterior part. And let's remember that the anterior and the lateral canals are innervated by the superior vestibular nerve with the utriculus. And the ampulla of the posterior and the sacculus are innervated by the inferior vestibular nerve. In between the osseal part and the membranous part, we will have the perilymphatic liquid, and inside the membranous part, we will have the endolymphatic liquid that we will talk about in this talk. Remember that the anterior and the posterior canals share the common cross, which will fall into the vestibule together. And so this is very important for some maneuvers that we will talk about. So this is a landscape from my country. It's a lake called Atitlan, and it is surrounded by volcanoes. We have 33 volcanoes here in Guatemala. It's a volcanoes land here. So another concept very important to review before beginning to talk about BPPV are the flows that we have in the every canal. So here we have a representation of the posterior semicircular canal. Here we have the non-ampular and the ampular area, the utrical part and the ampular side. And here we have, for example, when we move the head forward, we can displace the endolymphatic in the posterior part, and we will deflect the ampulla in the area or through the ampular side, and it will be known as the ampulipetal flow or ampulipetal deflection, from the Latin petere, which means search. If we have the opposite, the flow moving away from the ampulla, it will be called ampulifugal flow, from Latin fugare, which means going away. And something very important to remember is that in the vertical canals, the ampulipetal flow will be an inhibitory stimulus, whereas in the opposite direction, I mean in the ampulifugal flow or ampulifugal deflection of the ampulla, it will be an excitatory stimulus, which will be the opposite in the lateral canals. Other very important bases to remember are the Ewell's laws. Here we have the first that states that a stimulation of the semicircular canal causes a movement of the eyes in the plane of the stimulated canal. The second states that an horizontal semicircular canal in the ampulipetal endolymph movement produces a greater stimulation than an ampulifugal one. And in the horizontal canals, an ampulipetal is excitatory, and an ampulifugal will be inhibitory. And the third law states that it's the opposite that in the second law. We will be a summary here. Here we have the lateral canal, and ampulipetal flow excites, and an ampulifugal flow inhibits. But the opposite is in the vertical canals. Ampulipetal inhibit and an ampulifugal will excite. So another base is very important to remember is that an inhibitory stimulus is similar to an excitatory stimulus of the coplanar canal, but in less intensity. And how can be this understood? Here we have a representation of all the senses of the semicircular canals. For example, if we have a stimulation of the posterior left canal, then we will have a upbeating nystagmus. But if we have an inhibitory of this canal, then it's like the left anterior canal will predominate, and then we will have a downbeating nystagmus. And since comparing these two stimulus, an excitatory and inhibitory of the same canal, then the excitatory will always produce a more intense nystagmus than an inhibitory stimulus. Excitatory more intense than an inhibitory stimulus. We have to remember that. So going with the BPPV, we can see that the frequency of every canal being the posterior, the most frequently found. And how will we find the nystagmus in the posterior canal going with the posterior canal? So it will be an upbeating nystagmus with torsional component toward the ipsilateral side. And when we sit back the patient, it will invert the nystagmus, meaning that we will have a downbeating when we sit the patient back. The difference between the canal lithiasis and cupular lithiasis will be the time that it lasts. In canal lithiasis, it will last less than 1 minute, but in the cupular lithiasis, it will last more than 1 minute usually. And here we have a representation of the canal lithiasis are floating freely in the canal, and in the cupular lithiasis, we have the otoliths adhered to the cupula. And what does it do in the, what does this cause in the cupula? It causes like a heavy cupula, meaning that the gravity will bend it in the direction of the gravity, okay? So here we have the weight that the otoliths do over the cupula. And here we have a photograph of surgery of a patient with the otoliths floating freely in the canal. So in order to try to understand the physiopathology of this disease, we decided this helmet to try to understand what is happening in every movement of every maneuver. So we have a representation here of the anterior canal. If you see the blue mark here is the ampular side of the canal, the ampular of the anterior, the non-ampular with the common cross, the lateral canal. Remember that the lateral is 30 degrees over the horizontal plane, and we can remove the vertical canals in order to evaluate just the horizontal. So we will go to the maneuvers to diagnose the Dix-Hallpike, and we're going to analyze every step of the maneuver. For example, here we are turning the head in the 45 degrees to the affected side. We are laying down the patient, and you can see we are having an ampulifugal flow, which in the posterior canal, it's an excitatory stimulus, producing a vertical upward nystagmus. And then when the otoliths stop, then the nystagmus will stop. But the Dix-Hallpike maneuver should always be performed with the sitting position again. So in this case, we will have an ampulipetal flow, which in the vertical canals is an inhibitory. If we inhibit the posterior canal, then we will have a downbeating nystagmus. We will see we will see this in this patient. She had a posterior BPPV. So here is a video of the Dix-Hallpike maneuver. You can see the latency, and then it begins with the crescendo fashion. Here is the upbeating phase of the nystagmus. And then you can see that it will stop, okay? And then the patient is sitting back, and you can see how the nystagmus will become downbeating, okay? Following the principles that we already talked, okay? So what options do we have to treat the posterior canal? The Epley maneuver, cement, which is useful for canalo and cupulolithiasis, and in some cases when we have jams in the canals, we can use the Brandarov exercises. We can see here how the reposition is performed, is useful or successful in as much as 95%. You can see it's like the beginning of the Dix-Hallpike maneuver, and then it's very important to avoid the patient to flexionate the neck in order not to return the otoliths to the anterior to the ampular region. Then we rotate 90 degrees in every step. As you can see here, the otoliths are going into the vestibule part of the common cross, as you can see. So we moved the otoliths from the ampular region to the non-ampular region of the canal. And here I will share you some video of the, in my opinion, is the main cause of failure of this maneuver. You can see here is the otolith. Here are the otoliths. We turn the head to the affected side, then we lay back the patient. But sometimes the patient tend not to turn the head to the opposite side in the extensive fashion. If not, they can do a flexion of the neck like this. And then, as you can see, the otoliths can move back here. And when we see the patient, so we didn't move the otoliths. We didn't pass the otoliths to this area, or we did it incompletely. So that's something to remember. Some good prognosis that we perform a very good maneuver is that we must have an downbeating nystagmus in the third step of the maneuver. So we are going to move to the next maneuver, which is the Semot maneuver. It's a liberatory type, which means that it is based on the centrifugal forces. It is useful for both canalo and cupulolithiasis. It is performed, we turn the head to the healthy side, and then we'll lay the patient looking to the ceiling, and then moving very fast to the healthy side. It is a very fast movement. So we will see some examples. You can see here a bad maneuver. See, this is again the helmet. Here is the first part of the maneuver. You can see the otoliths here, representing the otoliths here. And then if we perform this maneuver very slow, then we are just going to move in this part, but we are not move it to the non-ampular region. So this is the correct way of performing the Semont maneuver. As you can see, we begin with the same. We go like this. And this is the important part. We have to move it very fast in order to seize the ampullary, the centrifugal forces. And then we moved to the common cross, these otoliths, okay? So, and here are the Brandarov exercises, which are, as I said, we use it for patients with, when we have a patient refractory to the treatment already mentioned, or where when we have jams in the canals. So it is performed turning the head toward the ceiling, then wait for 2 minutes, then do the opposite in the other side. And moving to the anterior canal, we know that this is the less frequent canal. It is diagnosed with the disc Gholap maneuver, and we will have a downbeating nystagmus with torsional component toward the ipsilateral side or to the affected side. Here we have a video from Dr. Hain. You can see here they are performing whether the disc Gholap maneuver or the head hanging maneuver to diagnose the BPPV. So the patient is laying back, and you can see the downbeating. And this is the less frequent BPPV because anatomically it is in the most easy way to cure, because here we have a representation of the anterior canal. In this case, we put the otoliths here, and for example, if the patient we lay back the patient like this, almost like disc Gholap, just like in the center. It's called the hand position. Then we flexionate 30 degrees, and then we move the otoliths to the common crus, wait for 30 seconds, and then we sit the patient, and you see we move the otoliths from this part to the common crus, and then they enter to the vestibule. So, but we can have an downbeating nystagmus having an otoliths in the posterior canal, and this was described by Banucci and the collaborators. Here we have this was named the Geo-Tropic posterior semicircular canal in BPPV. And what's the theory about this? That in this case we have a representation of the posterior right canal, and it is thought that there are some jams in the canal that can cause that when we perform the disc Gholap maneuver, the otoliths are not here. Instead, they are in the anterior part of the canal. So remember that in the disc Gholap, we move the otoliths in this fashion, meaning that is an ampulifugal. But when we have the otoliths here, if we perform this maneuver, then we are going to have an ampulipetal flow, meaning that ampulipetal is an inhibitory. So if we inhibit the posterior canal, then we are going to have a downbeating nystagmus, and that is why these patients may have a downbeating nystagmus when we perform the disc Gholap maneuver. So what is the treatment for this type of patients? They describe the demi-Semot maneuver, which consists in turning the head to the healthy side of the patient and then laying down toward to the floor, the face toward the floor, and then wait for 30 to 40 seconds. This is performed very fast with the idea of releasing these otoliths to get into the vestibule. And what happens here is that when the patient goes facing the floor, they can have a upbeating nystagmus. And why? Because then they are going to have the opposite movement than in the disc Gholap maneuver. And this is performed for 5 times until the nystagmus disappear. Another option for this is what is known as the 40-degree forced prolonged position technique, which consists in turning the head like this and asking the patient to remain in this position for at least 8 hours, which was one of the first therapies that they used for treating the lateral canal BPPV. So, but you can see here they performed both techniques And here is the total of patients treated with this variant of the canal. And they both had some degree of success, but obviously they prefer the demi-Semont maneuver because it is less, it's more rapid to treat. Moving into the lateral canals, then we're going to say that we're going to have two main types, the canal lithiasis and the cupular lithiasis. In the canal lithiasis, we are going to have a bilateral horizontal geotropic nystagmus. Geotropic means that the first phase of the nystagmus will be toward the floor. And how do we know which canal is affected? We will know because the more intense, the side where we have the more intense nystagmus is going to be the affected side. We can have another variant in the anterior arm of the lateral canal, and we can have an apogeotropic nystagmus, but it will last less than 1 minute. And in the case of the cupular lithiasis, it will be a bilateral horizontal nystagmus too, but it will be an apogeotropic, meaning that the first phase of the nystagmus will be away from the floor, and the affected side will be the side with the less intense nystagmus. Sometimes it can be a little bit confusing to remember this. We are going to take a look to another way to remember. We diagnose this with the roll test supine maneuver. First, with the patient and on the table, we turn the head to the right and then to the left. It is recommended to perform this at 30 degrees because remember that the lateral canal is oriented 30 degrees from the horizontal plane. So something to useful to remember this is that the first phase of the more intense nystagmus will point to the affected side regardless of geotropic or apogeotropic. It's another way to remember, and in this way we can get to know which side is the affected because, as you know, we will have nystagmus to both sides. Okay, so something to very useful to understand is this diagram. Here we are going to represent the in order to understand the physiopathology of the nystagmus, we are going to analyze this part. This will represent the canalolithiasis, meaning that the canals are floating in the canal, and in the lower part we are going to talk about the cupulolithiasis, the physiopathology. So imagine this is a left lateral canal, meaning this is this side, and we have here the ampular and the non-ampular part of the canal, and here we have the otoliths floating in the canal. So when we turn the head to the left, you can see that we have an ampulipetal flow, and in the lateral canal, an ampulipetal flow excites this canal. So it means that we will excite the left canal, and if we excite the left canal, we are going to have a left beating nystagmus, meaning that it will beat to the floor, toward the floor, okay? And if we turn the head to the right, then we are going to have an ampulifugal flow. If we have ampulifugal, we are going to have an inhibitory stimulus of the left canal. If we inhibit the left canal, then we are going to have a right beating nystagmus and the patient facing to the right. So we will have a geotropic nystagmus beating to the floor, okay? So in the case of the cupulolithiasis, meaning the same left canal, and here we have the otoliths stick to the cupula. So if we turn the head to the left, then we are going to have an ampulifugal flow. If we have an ampulifugal flow, it will inhibit the left canal, and then we are going to have a right beating nystagmus, but the patient is facing to the left. So we will have an apogeotropic nystagmus. It means beating away from the floor. If we turn the head to the right, then we are going to have an ampulipetal displacement of the cupula, and then we are going to have an excitatory stimulus of the left canal, and then we are going to have a left beating nystagmus, but the patient is with the head towards the right. So it will beat opposite to the floor, meaning that it will be an apogiotropic nystagmus. And what, as you can see, here we had an ampulifugal flow, meaning inhibitory. So, but this side is the affected. So that is why we have to look for the less intense side nystagmus, because it is the side that will be affected in the cupulolithiasis, the side where it was less intense than nystagmus. So, and this is an example of how the otoliths deflect the cupula, making it heavy. And so we have here a summary of what we just taught. So we are going to see some examples. Here is a patient. Here is, as you can see, she has some type of pseudo-nystagmus. We will talk about a little bit forward about this. You can see they turn the head to the right, and then when they turn the head to the right, then we can see an beating, nystagmus beating to the right, meaning that it is a geotropic nystagmus, okay? So then we move the head to the left, and you can see that it's a little bit more intense, but it changes direction. It changes, now it's beating to the left, meaning that it's geotropic, it's following the Ewell's law. So, but I recommend you to always double check which is the more intense nystagmus. So in this case, you will see he will turn the head again to the right, and you can see now it is more intense, the nystagmus to the right. So in this case, if we have an geotropic variant of the lateral canal, then we know that we are going to look for the more intense side, meaning that in this case, she had a right lateral canalolithiasis, or a geotropic variant of the lateral BPPV. So we are going to take a look to this video. I want you to watch very careful this patient. I will stop here this video. You can see that he's sitting, but he is having what is known as pseudo-spontaneous nystagmus, which means that it will have an horizontal nystagmus depending on the movement of the otoliths in the canal. So now we will continue. You can see that he is turning the head now to the right, okay? He continues with the pseudo-spontaneous nystagmus that he already had, and then turn the head to the left. When turning the head to the left, changes direction, it goes to the right, meaning that it's apogiotropic, okay? Because the head is to the left and it's beating to the right, okay? Then he will move the head to the right. I will go a little bit faster here. So moving the head to the right, and you will see how it changes direction. If we have an apogiotropic, then we have an cupulolithiasis variant of the VPPV. So it will stop here, the nystagmus, and then it will start beating toward to the left, meaning that it will be an apogiotropic. But as you can see, this side was the less intense. So in the cupulolithiasis, we have to look for the less intense nystagmus, which in this case, the less intense was the right side. So this patient has a right cupulolithiasis, okay? So we are going to move to the same patient after liberatory maneuver. Remember that he had a right apogeotropic variant. So we will see now he doesn't have the spontaneous nystagmus. Now it's turning the head to the left, and you can see that now he has a geotropic variant. So meaning that after the liberatory maneuver, it became from cupulolithiasis to canalolithiasis because it is beating to the floor. Okay. So, and you remember that the right side was the less intense. Now that he has a canalolithiasis, the right side will be the more intense nystagmus, as you can see, and is a geotropic nystagmus. As you can see, it will be decrease the intensity. And so after this, they performed the treatment for the canalolithiasis, and that was all. So, and there is something called the pseudo-spontaneous nystagmus and the lateral BPPV. As much as 16% of the cases, it is not possible to determine the affected site. And that is why it is useful to understand the pseudo-spontaneous nystagmus, which is present in 76% of the cases. This is the paper of the bow and limb test, which talk about these maneuvers. And basically it says that you can move the patient in a bowing position and then in a lean position in order to create flows in the canals that will indicate which side is the affected. Here we can see an example. If remember that if the canal is 30 degrees in this over the horizontal, we move the head toward the forward, and then we will, if we have an apogeotropic variant, then which will be this scenario, and then the cupula will deflect in the ampulifugal way or in the ampulifugal pattern. So if we have an ampulifugal deflection, then we are going to have an inhibitory. This is the right canal. So if we inhibit the right canal, then we are going to have a left beating nystagmus that as you can see, is what is represented here. And if we have the geotropic variant, then when we move the head forward, then we're going to have an ampulipetal deflection. And if we have an ampulipetal, we are going to have an excitatory of the right canal. Then we are going to have a nystagmus beating to the right. In the case that we perform the lean position, meaning that it's going backward, if we have the apogeotropic variant, we move the canal like this, then we're going to deflect in ampulipetal fashion, and it will excite the right canal. So we are going to have a right beating nystagmus in the apogeotropic. In the geotropic variant, if we move the head like this, then we are going to have an ampulifugal deflection, meaning inhibitory. Then we will inhibit the right, and then we are going to have a left beating nystagmus. So we are going to give you an example how this is performed. So 30 degree, the lateral canal, then we put to 0 degree. In this case, we should have a stop the nystagmus because the otoliths are not moving. If we move in the front, then we are going to displace the otolith like this. And then if we move like this, the otoliths will move in the ampulifugal fashion. Okay, this is another landscape here in Guatemala. This is not anymore because we had an eruption of the volcano. So what options do we have to treat the lateral canal? Then we have the liberatory maneuvers, the Bufoni, head shake, Amit, Banucci, Asprella, and the reposition maneuvers, the Bufoni, barbecue, and the Sumaya maneuvers. In the geotropic way, we have all of these maneuvers, and the apogeotropic, we are going to have these maneuvers. Even though some of them can work for both the geo and the apogeotropic variant. So we are going to see the maneuvers. We have the barbecue maneuver, which is indicated for the canal lithiasis. As you can see, the head will turn every 90 degrees until they finish with the 360 degrees. But I will show you why I perform this maneuver only 270 degree. We lay the patient like this. We turn the head to the affected side in order to bring all the otoliths to the same part. Then we move 90 degrees, wait for 1 minute. Then we turn the head other 90 degrees, wait for 1 minute more. Then we turn another 90 degree, and we will finish the 270 degree. And as you can see in this part of the maneuver, the otoliths will enter into the vestibule. So it's not necessary to perform the 370 because you can have otoliths going in this way. So what prognosis do you have to know that you perform a very good maneuver? Is when you have a nystagmus toward the healthy side, it means that you are going to have an ampulifugal flow. And if you have a weakness of the nystagmus, or when it disappears when you are performing the maneuver. And a ground perform maneuver is when you have a nystagmus beating to the affected side. It means that you are going to have an ampulipetal flow. Or if you have a torsional nystagmus, meaning that the otoliths went to the posterior canal. So here we have the Bufoni maneuver. This is going to be for the geotropic variant, meaning that it's for the canalolithiasis. It begins with the patient in this position, meaning to the healthy side. Wait for 2 minutes, then the face to the floor, toward the floor, for other 2 minutes, and then the patient sits. We're going to perform this for 3 or 4 times until the nystagmus disappears. This is the principle. I always do this first. This is additional to the maneuver, to the original. And then we continue as the Bufoni says. So then we turn the head to the floor, and as you can see, the otoliths enter to the vestibule. That's the principle of that. So what maneuvers do we have to treat the cupulolithiasis in apogeotropic? In the apogeotropic variant, we will lay the patient into the affected side, wait for 2 minutes, then look into the ceiling for other 2 minutes, and then sit in the patient. As you will see here, the objective is to wait for 2 minutes here, waiting for the otoliths to fall into the canal and to get free into the canal, and then turning the head up to make sure that they are flowing freely. Other option is to perform a head shake in the case of the otoliths adhered to the ampullary side of the canal. And then, as you can see, we expect to release the otoliths and become into a canal lithiasis. The other technique is the Amit technique, which consists in beating the patient's head toward the table in order to release the otoliths from the ampullary region. The other is the Vanucci asprella, which is useful for the canal lithiasis and cupulolithiasis. As you can see, they bring the patient like this, turn the head to the healthy side, then sitting the patient. This is performed very fast, and it is performed 5 or sometimes even as much as 20 times in order to release the otoliths. And the other one is the Sumaya Maneuver. You will see here is the beginning of the technique of this maneuver. The patient lays into the affected side, wait for 2 minutes, then rotate 90 degrees to the healthy side, other 90 degrees, and then wait for 3 minutes in every step. And then we see the patient, as you will see. This is the Professor Suma performing the maneuver. Here is the example how the otoliths are moving. 90 degrees to the healthy side, then other 90 degrees to the healthy side, and then they wait for 3 minutes in every step and then sit in the patient. So we are going to see some cases. This is some cases that I just saw. You can see here a patient with horizontal symptoms. We are turning the head to the right, and you can see he has an apogeotropic nystagmus. It's beating to the left and the head is turned to the right. Okay, it is a very strong nystagmus, as you can see. We're going to go a little bit more forward. Okay, so it lasted for around 3 minutes and disappeared. Then we turn the head to the left, and you can see he has an right beating nystagmus, meaning that it is an apogeotropic variant. Okay. So we are going to do an exercise. Remember that the other way to remember what is the affected side is watching the fast phase of the more intense nystagmus. In this patient, the more intense nystagmus was when he turned to the right. So, but the fast phase was beating to the left. So, meaning that the left canal was the affected. So he had a lateral cupulolithiasis BPPV. So after this, we performed the maneuvers to treat. We performed the Bufoni Maneuver to release the otoliths, and then we perform again the roll test. And you can see, remember that before it was a apogeotropic, now he has a geotropic nystagmus. But do you remember that this side was the more intense side, and now it has a very, very weak nystagmus. So now we perform the roll test to the left side, and you remember this was the less intense side, and now he has a geotropic nystagmus with more intense to this side, meaning that we have converted the cupulolithiasis into a canalolithiasis, okay, of the left canal. So, and now after half an hour, we check how is the patient, and you can see now he has no nystagmus, meaning that we have resolved the canalolithiasis, okay? Okay, now we turn the head to the left, which was the affected side. The patient has fear to turn the head because he has very, very intense nystagmus. Now, as you can see, there's no more nystagmus, and the patient was well. However, after 1 week, he called me and told me, hey, doctor, I think I have nystagmus. I have vertigo, but this time is when I lay back. So we perform one Dix-Hallpike maneuver. As you can see, now he has a posterior BPPV. So in this patient, we sent vitamin D level, and the vitamin level was very low. So we began to prescribe the vitamin D. And then we see the patient, as you can see, when we see the patient, you can see the inversion of the nystagmus, then he has a downbeating nystagmus. Okay, so then we treated the posterior canal and everything is fine. So he is like 3 weeks free of vertigo. And what about to verify the maneuvers? I don't know if you perform this technique to verify immediately after the maneuvers. I used to do this, but after these cases, I wait for half an hour, and then I check if everything is okay. So this patient had a vertigo when laying back, so we performed a Dix-Hallpike maneuver, As you can see, we perform the maneuver to the right, and you can see she's having an upbeating nystagmus with torsional to the ipsilateral side. So we diagnosed a posterior BPPV, posterior canal BPPV. After the Epley maneuver, then we go and check if everything is fine. As you can see, then we move to the disc hole again, and now you can see my expression here that I moved the otoliths to the lateral canal because now she has an horizontal canal. So it's very important to highlight this because the fact that you perform a disc hole maneuver doesn't mean that you will always have an vertical nystagmus. In this case, we had an horizontal canal or horizontal nystagmus, meaning that we had we have converted the BPPV into a lateral BPPV. So now she's having the head to the left and she's having the left beating nystagmus, and obviously the right side was the more intense because she had a geotropic variant of the BPPV. So after, even we performed the pseudonystagmus test to check the pseudonystagmus, and you can see she is having a pseudo-spontaneous nystagmus. Okay, so after all this, then we perform the barbecue and Bufoni maneuvers, and then we are going to check how is everything after all of this. And as you can see, she's not having nystagmus anymore. To the roll test to the right, and then we move to the left, and there is no nystagmus anymore. So, but one of the things I want to remember you is that not everything is BPPV. Sometimes we can have nystagmus like this patient. She had a history of highlighted of lightheadedness, and so she had some family history of migraine. So we performed here, my professor, Dr. Ceballos, who I thank for all of these videos. As you can see, she's having a very, very weak, low downbeating nystagmus. This is very, very frequently found in migraine patients. This is a central BPPV. This is a central postural kind of vertigo. You can see that the patient has not the crescendo characteristic of the BPPV. So now he is going to perform the left disc hole pike. As you can see, here is the downbeating. She resolved this dizziness with treatment to migraine. So some of the questions that we usually perform are these. I think that the panelists will discuss a little bit about this. We are going to move forward. And one of the things I want to say is that this paper, it seems to me very interesting because it was trying to explain what to indicate the restriction maneuvers after we perform these techniques. So it was I'm sorry for the slide in Spanish. It was in frogs, and what they did was to use the otoliths of the saculum, and they put it in the macula of the utriculum, trying to simulate the free otoliths going into the utricle, and they measured the stability of the otoliths at the 3 and 5 minutes during 10 seconds. Here we're going to see an example. They put the otoliths of the saculum on the macula of the utricle, then put the utricle in this fashion, and then wait for 10 seconds and to see what happened with the otoliths. So the macula can have different scenarios. In this case, they used 3 different scenarios. In this case, they didn't touch the macula of the utricle. In this, they removed partially the macula of the utricle. And then in this scenario, they removed completely the macula of the utricle. So, and then they put the utricle in this fashion and see what happened. Here is a representation of the utricle macula with the otoconia. And here we can see another example of the otoconia over the utricle. So, and then what happened with this? What they found was that in the experiment number 1, they found that the otoliths of the sacculum adhered completely immediately to the utricle macula, meaning in the intact macula of the utricle. But as you can see, if the macula of the utricle is removed, then we are going to have more time to adhere to the macula. So what this is trying to show is that the otoliths adhere very fast to the intact macula. So, and that's because they are opposed to the fact of restriction maneuvers after the reposition maneuvers. Okay, so they say this is not necessary to indicate those restriction maneuvers, and that was what I had for you. So I move now to the next part. I will stop sharing my screen.
Thank you very much for your lucid presentation, Carlos, and it was quite a nice, and I think we will take a few questions from the panelists, and I think your model was
I'm unmuting. I'm unmuting them, yeah.
Yes, unmuting. Dr. Sonali, Dr. Sreeram, and Dr. Swaranand.
Yes. Dr. Swaranand is unmuted, then Dr. Sonali, yeah. Yeah, she is also ready. Then Sreeram. Okay. Sreeram and video. Sreeram's video. Okay, asked to start video. Yeah, fine.
So, Carlos, I will ask questions to the panelists, and then when you have to add something, you can add to the panel questions. So we have around 10 questions, so we will take it one by one. The one question, the first is that, is there a classification called primary BPPV or secondary BPPV? Means it is a primarily BPPV, or there is some other causes of vertigo, and then BPPV can come together. So it is good to qualify. Dr. Sreeram, your comments?
Yeah, I will. Okay. So actually, in my opinion, it's actually doesn't vary much, because in clinical situation, there are multiple risk factors. Now, the recent studies have come. There are multiple risk factors for BPPV. So low vitamin D is a risk factor. Then low calcium is a risk factor. The ear disease is a risk factor. The aging is a risk factor. Female gender itself is a risk factor. Then trauma is a risk factor. Prolonged positioning is a risk factor. Then and other comorbidities like diabetes mellitus, hypertension, dyslipidemia, hypothyroidism, hyperparathyroidism. These are all kind of risk factors. So, so saying it as primary and secondary doesn't value much in clinical situations. So you have to, for in my opinion, you have to do a risk factor assessment in each case of BPPV. If young individuals, you have to check for the migraine, low vitamin D, that means trauma, position, the prolonged positioning, and these factors. For elderly patients, you have to check for the comorbidities. And in my opinion, what are risk factors? There are some risk factors are modifiable, like low vitamin D, it is modifiable. Some are preventable, like trauma, the prolonged position. These are all preventable risk factors. So such way you can modify the risk factors. Some are modifiable, some are preventable, and some are controllable. So in this fashion, you can modify the risk factors, and you can do. So it doesn't value much in clinical situations.
Right.
Can I add something to it?
Yes.
Yeah. So in all cases of, we have primarily a primary or idiopathic BPPV and secondary BPPV, where either there is an association or there could be because of some other inner ear disease, we have BPPV. Only thing which I want to add here, sometimes we overlook, or we are so busy in diagnosing or treating the primary pathology, we sometimes don't look towards the BPPV features that much, because patients also don't tell you the exact, because there's a, sometimes they may not tell you the exact spinning sensation. They might just tell you that they feel dizzy.
That they are having the vertigo again.
Yeah. So, and treatment wise, in a lot of papers they have, they're saying that you need more positioning, canalatory positioning maneuver for secondary BPPV. For example, in Meniere's disease, you can get the fibrosis of the labyrinth, the membranous labyrinth. You can have because of the saccular utricular degeneration, because of the distension, endolymphatic distension.
Right,
so you may need more repositioning maneuver, and it's better when you counsel the patient to tell them that, okay, this is a BPPV
Different.
where we have to kind of, you may need further like 2 or 3 maneuvers till you get better.
Okay. So my next question to Dr. Swaranand, that many a time BPPV is recurrent. So as Dr. Sreeram mentioned that maybe vitamin D and other causes are there. How do you prevent recurrence? What do you tell your patient? And if there's a recurrent BPPV, what do you look for specifically?
Well, I will just look basically, as Dr. Sreeram told us, that vitamin D levels important. We have to check the thyroid levels to look for any hypothyroidism. Okay, so these are the 2 main things we have to look for. And one more thing I want to add in a factor that about the previous question, that I have seen BPPV in patients, especially old patients who has got long stay in the ICU, because they remain in the one position for a long time.
Yes.
And you get the call that patient is having giddiness, all the other causes are ruled out, and patient is having BPPV. So this is one I want to just add.
Dr. Sreeram mentioned it briefly. So what is the level of, Carlos, what is the level of vitamin D you are looking at? Because in India, we tell that it is 50 IU, where it is less than that is a little risk factor. What is your take on vitamin D? And
okay, it will depend of the laboratory, but here the normal range is above 30, but it is classified in sufficient and deficient, going down 10 points down, but it should be up to 30.
So can I add to it?
yes.
So actually, we need in my knowledge, we need to keep the vitamin D 40 to 60 at least. It should be above 40 and should near 60 is a better value. Below 30 is considered risk group, and below 20 is considered high risk group.
Right. So what is the? You have done a maneuver, and the patient comes back again. Vitamin D is normal. So what is the problem? Have you the post-procedure advice you give to any patient? Is that the important factor for the reoccurrence? If the vitamin D is normal, all other factors are taken care of. So do you give any post-procedure exercise, or do you advise your patient for having recurrent symptoms, maybe that they are coming 2 weeks later, and there is no risk factor for the recurrent BPPV? Then what is your opinion? Dr. Sonali, can you comment on this?
Yeah, I first think we have to be very sure that we have done the maneuver correctly.
Correctly, right?
Okay, that's the first thing. And if the patient is coming back, usually I instruct them not to do jerky head movements. Previously, I used to tell them not to lie on the same side for 24 hours. Sometimes they are so apprehensive that they themselves will not lie on that side because of the fear. But I think a lot of studies are now have shown that it doesn't make a huge difference if you have done the maneuver correctly. So nowadays, I just tell them to avoid jerky head movements. And if they come back to me again and again 2 or 3 times, then probably my threshold, and I'm sure that I've done the maneuvers correctly and my diagnosis is right, then I would advise a full vestibulometry of vestibular workup and maybe MRI also.
To think about migraine, because the symptoms may be like that one time you have done the maneuver and it was right, and the patient has some history. So I mean, sometimes migraine also can cause symptoms of BPPV. The other question is that how do you know, Carlos, that we have a jammed canal? I mean, the particles are not moving. Is there any way to find out and use virometer for that? How do you use that?
Okay, yeah, I have had some cases when you perform the maneuver and the patient is refractory to that, and the patient you perform the maneuver for the diagnosis, you find that it follows all the peripheral laws, but when you perform the maneuvers, the nystagmus persists. So what I do in those cases, after checking all that, I remember one case that I had which was because of the vitamin D. I mean that because I did all of the maneuvers that you can imagine for acute lithiasis of the lateral semicircular canal. I did vibration, everything you can imagine, and nothing worked. So I measured the vitamin D, it was very low. Then I began to reestablish the levels, and with no other maneuver, it resolved. And this patient had this vertigo for more than 1 month. After taking the medicine, the vitamin D for 15 days, the patient was perfect. And the other is, as I mentioned before, in the case of the posterior canal apogeotropic, you can check this. If you perform the Dix-Hallpike and then you have a downbeating nystagmus, then you perform the other maneuver to the patient laying in front of the table, and then you will have an upbeating nystagmus. Then it will tell you that it is the most probably diagnosis is a jam in the anterior part of the posterior semicircular canal.
Can I add to that?
Yes, sure.
Okay, so
please stop. Dr. Viswanathan's screen is being shared. Can you please stop it? Yes, thank you.
Okay, so can I add to that?
Yes,
okay,
sure.
Okay. Very rarely we can come across the situation like jammed canal. So when you do a Dix-Hallpike maneuver and you confirm the diagnosis, when you do a repercussion maneuver, occasionally you get a situation like it remains as spontaneous persistent nystagmus. So that is a sign you should suspect the jammed canal. So you can try liberatory maneuver and all, as Carlos said. And adding to Carlos' one point, we had a situation like a situation when we do the position test, we get typical nystagmus and all, but it is refractory. Interestingly, it was refracted to all kind of positioning manuals. So we added to that, he had some crust in the nasal cavity, and it was actually a granulomatous disease, vaginous granulovatosis. So in very rare situations like granulomatous disease and autoimmune conditions, you can get a situation called light cupula. So or heavy enterolip. It is described in some studies. So it's actually the ionic imbalance which causing this the persistent nystagmus and vertigo. And the treatment is to treat the primary cause. Okay. So once we diagnose the vaginous the disease, and once it got resolved, it spontaneously the nystagmus also subsided and his vertigo also subsided. It took actually 2 to 4 weeks 4 weeks for this to be disappear.
Okay. Dr. Swaranand, can you just enumerate that? Do you use any vestibular sedative, beta-aztine, or any of the vestibular sedative in your patient of BPPV? You have diagnosed that it is a patient of BPPV. Do you use them? If you use them, what is your rationale and how much time you use them?
No, if I diagnose the case of BPPV, then I do the maneuvers, okay? And I don't use the vestibular sedatives.
Okay, okay. Carlos, yes?
Can I comment something? Just to add something?
Okay.
Your patient.
Yes, Carlos.
Sorry.
Yeah, Carlos want to add something. Can just a minute.
Okay. Just I want to add something. We have since we have residents here, maybe I want to add something. Let's keep in mind that always have to think that when we have a BPPV, to remember that we can have other diagnoses. I have remember one case of, and it's described that you can have a persistent posterior canal BPPV in lesions around the fourth ventricle in the posterior fossa. So it is always useful to think about that when we have persistent this vertigo, we have to study other causes like tumors.
Think about the signal causes like migraine and other tumors and all that. So yeah. I mean, in your presentation, you told there was the bilateral BPPV. In my also career also, I get bilateral BPPV. So what is your approach to the bilateral BPPV? You do them together or you stage them? How do you do? And do you use vestibular sedatives anytime in BPPV?
Me?
Yes.
Okay. Yeah, when we have bilateral BPPV, is always the most common is for trauma, and never do it in the same time. You always have to ask the patient what is the most symptomatic side. You resolve the first, then you say come back in 2 days and we perform the second maneuver. And generally that's enough. Okay, and sedative and betahistine and that, as my colleague here, I don't use them except for those cases like I use when I converted into a horizontal canal. Then I give something to this patient because he's going to be like nausea, but I don't use them if I perform the maneuver. And personally, adding to what the doctora said, if we perform a good maneuver, then there shouldn't be any problem. But how can we be sure? Then we must check the maneuver, as I showed you that we always check half an hour after the maneuver to see that there's no more nystagmus, and then we are more happy with that.
But in my clinical practice, I mean, just to add on, we don't use it, but sometimes patient is a bit symptomatic when you do your exercise. I mean, after the maneuver, the patient is a bit symptomatic. Sometimes they also throw up during the maneuver. So I train to give 1 or 2 doses and they feel comfortable after that. So maybe, I mean, we should not use, but in few cases we can use. Dr. Sonali and Dr. Sreeram, do you use vestibular sedatives sometimes?
Only like, just as you said, if the patient has nausea, and
okay.
if you, ideally, if the patient has severe nausea and vomiting, you shouldn't be probably attempt it, the repositioning maneuver, probably give him some vestibular suppressant for a day or so and then call back. That's what I do. I don't know what others do, but that's, if severe nausea and vomiting, usually give them vestibular sedative for a day and then call them back for repositioning maneuver. And usually post maneuver, I don't give them if I'm sure about BPPV, but I explain them that they may feel lightheaded and dizzy in the head, and you just have to counsel them. And usually you don't need to give anything. That's usual, not a usual practice to give them any vestibular sedative.
And then one of the popular question from everyone is, can you tell me one procedure for one canal? Okay, so I mean, Dr. Swaranand, what is your procedure for? Can you tell us about the posterior canal? What is your procedure of choice?
disc halpi, Epley's maneuver.
Epley's maneuver, right?
Yes.
So does anyone does the Simon maneuver for most of the times? First maneuver? Okay.
No.
So we got an answer that posterior it's Epley's. And then what is for the anterior canal? Dr. Sonali?
Yakovino maneuver. Yeah.
Yakovino, right. So we have the answer for the anterior canal. And for the lateral canal, I have two questions, Carlos. Can the null plane help us to find out that which side is the lateral canal BPVP? And what is your procedure of choice for lateral? Because what I understood that geotropic, geotropic go for Bufoni Maneuver, and apogeotropic, then what is your choice? Can you comment on this lateral canal?
Okay. Can you repeat the first question?
The first question is that if from the null plane,
normal plane,
neutral plane, can you find out that which side is the lateral canal BPVP?
Yeah, from the neutral plane, you can have an idea which is the affected, because remember that the lateral canal is 30 degrees. Okay, so if we have an ampulifugal flow, then we know that it's going to be in which side. So what will make me know if it is an apogeotropic or a geotropic? We can perform the maneuver in this side, okay? Then we observe if it's a geotropic or apogeotropic, and then we move the head to the other side, and then we can diagnose the lateral canal, which side is affected, with no laying back the patient. Only with this maneuver. This was described by Asprella, an Italian neuro-otologist, very famous, and he described the minimal stimulus maneuvers to diagnose the lateral BPPV, meaning that the patient will not have vomiting to you when you are performing the maneuvers, okay? So I saw that there was some question. The next question was, what is my
procedure of choice for lateral canal BPV?
What, the geo or the apogeotropic?
Geotropic, most of do Bufoni. I think you also do Bufoni.
The geotropic, yes. I prefer the barbecue maneuver for the geotropic, and for the apogeotropic, I use the Bufoni maneuver. And I saw one question that if there's a one stage maneuver for the lateral apogeotropic. As you can see, in apogeotropic, we have to convert to geotropic and then treat the geotropic. But there is this maneuver from the Professor Sumaya, which is in one stage for apogeotropic BPPV, and the Asprella is indicated too for both type of lateral canal.
Okay, right. So now the common question is that BPVP is easy to diagnose. You do the maneuver. So how do you know that you have done the maneuver properly? I mean, you have showed that we have to give a challenge the same situation, but you have to also see that you have to have not converted it to the other canal. Like the case you showed that the posterior canal you converted into the lateral canal. So, I mean, any tips on that? How do we know that we are doing the right maneuver and it has been done well?
Can I?
Yes, Dr. Sreeram, yes.
Sorry.
Okay, there is one thing called orthotropic nystagmus and a non-orthotropic nystagmus. So once you do a positioning maneuver, for example, a plea maneuver, so the first position, you know, the disc-halpic position, you get a nystagmus. And if the second position is showing the same nystagmus, it's called orthotropic nystagmus, and it's a positive sign, means a positive prognostic sign. So absence of orthotropic nystagmus is not a negative sign, but presence of orthotropic nystagmus is a positive sign. You are doing in the right direction. Okay. And in the presence of reverse nystagmus, like non-orthotropic nystagmus, you are getting a reverse nystagmus in the second position. Then it's a sign of, it's a negative sign, and you should suspect that your maneuver is going, you may not be effective. So there is no harm in rechecking that. So usually what we do, like Carlos said, we do repeat the maneuver after half an hour. Why? Because half an hour or 1 hour is that we should give some time so that autonomic symptoms will not be much. The vegetative symptoms will be less. A patient will be compliant. Patient will be compliant. So though it can, though the crystals can get settled in utricular macula within 5 minutes, as study says, you should, in my opinion, you should give some time so that once you repeat it, the vegetative symptoms are less.
So my next $1,000,000 question I will ask to all the panelists. Dr. Swaranand, in how many, means if you treat 100 cases of your vertigo, BPPV, which is the most common thing, how many times you have to do the same procedure again, 2 days to the patient? Maybe the symptom has decreased. I mean, what is your failure rates in BPPV?
Well, everybody has got failure rates.
Yes,
yes, but not much. Means most of the time, I feel that my maneuver is successful. As Dr. Sreeram told that while doing a Ippler's maneuver, as he told about the nystagmus, one more point I want to add: when you take the patient up in the last stage, if the patient doesn't feel giddy, then you are perfect in your position. Okay, so if you are that confident, then the failure rates are less.
Okay, so in the final position, do you keep neck a little extended, neutral, or little flexed?
I keep a little bit flexed, 5-degree flexed.
So, Dr. Sonali, your experience?
Yeah, I mean, ballpark figure, roughly, I would say around 80% of the patients are happy, 20% do come back. Approximate figure, I haven't really calculated.
Nobody has the significant figure. Dr. Sreeram?
So I will take that. So initial years when you used to practice, we usually call the patient after a week or 1 week or 2 weeks. Then we see that everything is all right, or in some patients it is, most of the patients are, but they complain that second day or third day they had vertigo, a few days they had some problem. So when we change the visit, revisit or review, it slightly means we used to review the patient every third day. So then we know that some patients do have the crystals are back in position, or there are remaining crystals. We should repeat the maneuver. It's not actually the failure rate. It's a fact. So it can take 1 or 2 maneuvers most commonly, at least 2 maneuvers, and in rare situation it can go for 3 or 4 maneuvers.
So Carlos, what is your experience? How many of your patients come back with the same kind of symptoms?
It is more or less the same as the colleague said. 80% are well, and then 20% may come back. Just want to highlight one comment of the. I had a slide here that maybe is the same that the colleague said. The good prognosis for a good Ippler maneuver is the inversion of the nystagmus in the third step of the Ippler maneuver, meaning that we are going to have a downbeating nystagmus, and in the lateral canals we have good prognosis and bad prognosis. The good prognosis for the lateral is that if we have a nystagmus toward the healthy side, meaning that we are having an ampulifugal flow, it's meaning that the otoliths are going away from the ampullary region and going to the vestibule. And if the nystagmus is going every time weaker, as long as we perform the maneuver, it means that we are doing well in the lateral canal. And the wrong performed maneuver is when we have an nystagmus beating toward the affected side, meaning that we are having an ampulipetal flow, meaning that the otoliths are going to the ampullary region of the canal. And of course, if we have a torsional nystagmus, meaning that we are going into the posterior canal.
Right. Thank you, Carlo. So the message is clear that it is not 100% success at one time. It is easy to diagnose. Sometimes you can have transitions to the other canals. Here we have a very good expert, Dr. Srinivas, who told me two things while doing this airplays and all that. The one thing he told me that he has to jump up from the table if it is possible, and it increase the success rate, especially in posterior canal. Dr. Srinivas, you are there?
He's there. Yeah.
Dr. Srinivas? Dr. Srinivas?
He has been unmuted, I think. He has been unmuted.
Dr. Prahlad, can you please unmute him? And then there is a question from Dr. Suratwala. Is he unmuted?
Srinivas, are you there?
I just saw briefly Dr.
Yeah,
Srinivas.
Amit, you just gave a very good point there. Srinivas always tells it, and I have performed it in my patients also.
Yes, and it gets
after doing applies and
you just tell the patient to,
especially in applies, when the patient sits back, you just say him to jump on the ground. So he jumps from the couch on the ground.
Yes,
so whatever remnant otoconia are there at the crux, at that opening common crux, they are getting in.
Dr. Srinivas is there. I can.
Yeah. The other thing is post maneuver.
I think Dr. Srinivas is with a baby.
Yeah.
A lot of disturbance there.
Post maneuver imbalance is there in a few patients. I think that is a good sign sometimes that you have done a maneuver well, but it doesn't last more than 3 or 5 days. So in that time, it is judicious to use sometimes, if the symptoms are much severe, to use anti-vertigo drugs.
Right. I also use in some of the patients, sir, because and one questions I think I need to ask, if any one of the panelists can take it, that do you sometime you are not, I mean, this is a typical BPPV, you are getting mild nystagmus and you're not able to find, the patient is vertiginous and he's on vestibular sedatives. So do you tell your patient in the next visit to stop the vestibular sedative and come back, or does they have any role on the nystagmus or the symptoms?
Can I take that?
Yes.
Okay, it doesn't actually. It should that maneuver or desulfate position test or position test should be done without the influence of vestibular suppressant. Right. But still, if they are on vestibular suppressant, there is no harm in doing the position test and the test it. And if found positive, we can correct it. And if found negative, there is a chance it is masking the vestibular suppressant. So we have to review with stopping means withholding the drug. That's my opinion.
Okay, right. So if there is any questions, any more questions?
Dr. Suratwala has a question.
Yes. Yes, Dr. Suratwala, sir.
Yeah. I have unmuted him. I think his voice, I'm not sure whether he's able to.
So we do have 2 minutes left. I think, Amit, you can thank Carlos.
No, Dr. Suratwala has a question. So what he has asked is residual dizziness, assurance, restricted movements, and VRT.
Yes.
Yeah, something he has asked. Has he asked something else earlier?
Yeah, it was the same thing which I discussed.
Okay, that's fine.
Right. Yeah. So, Carlos, I will not take much of your time because you have to go to your clinics. And,
no, don't worry.
Yeah. So, and it was a very lucid presentation. We really loved it. And with your permission, can we post this on YouTube? Or yes. Okay. So it will be available and it will be very beneficial for the postgraduate students and our fellows. Because I mean, I myself learned quite a few new things. And
I think you do have very learned panelists down there, Sonali and Sreeram. And
yes. And I think the panelists were quite informative from Dr. Sreeram, Dr. Sonali, and Dr. Swaranand. I thank you all. If you have some closing comment, I will ask my panelists, Dr. Sonali, Dr. Swaranand, and Dr. Sreeram, that if you want to give any message to take home masses while doing BPPV maneuvers, and then we call it a day.
Well, I can comment that BPPV is such a condition that for the patients who are having a BPPV, there is definitely a ray of hope, and definitely we can cure them.
Okay.
So it's a benign condition.
Sonali.
Yeah, my message would be in all patients of vertigo and dizziness, you do positioning maneuvers. Don't
Very
miss
important
them.
point. Very
Yeah.
important
Yes.
point,
Yeah.
and
Very important
we
point.
should always do it.
Yeah.
And such a treatable condition.
Yes.
It is totally treatable condition.
Dr. Sreeram.
So, in my opinion, BPV is not as simple as that. It has some difficulty.
Yes.
There are many difficult situations, like all upper geotropic variants are to be noted, and BPP with cupulolithiasis, that's also a difficult situation. Then multiple canal BPPV post-trauma, it's also one of the difficult situation. Then BPPV in bilateral ear, then BPPV with congenital nystagmus, BPPV in congenitally blind patient, BPPV in downbeat nystagmus with saccadic oscillation, then BPPV with extraocular muscle palsy, that's also a different situation.
Yes.
You will not get a torsional disturbance.
Diagnostic and therapeutic challenges.
So that's all challenges. That's all BPPV challenges. So BPPV in physical limitations, BPPV coupled with Meniere's migraine, these are all difficult. Every BPPV you have to be very cautious.
Sometimes it poses as a diagnostic challenge.
Definitely.
Most of the time you can diagnose it.
Definitely it can be diagnosed and it should be corrected.
Yeah. Carlos, I mean, there was a question also that how do you deal a patient with trauma and BPPV? How do you treat them? I think this will be the last your closing comments.
Yeah, well, always try to ask the patient the axis of the symptoms. It's always some kind of useful to ask the patient if he has, if there is a vertigo when laying back or with moving the head in the horizontal. And then because of the epidemiology, I will go first with the Dick's Hallpike. And if he has bilateral, as I said, first the most symptomatic and then the second 2 or 3 days later.
And there are also concussion causing vertigo, residual vertigo after the treatment of BPPV. The concussion, vestibular concussion after the head injury.
I'm sorry, I didn't.
I mean, the trauma to the vestibule itself.
Oh yeah, in this case I will leave the beta-histine because I am not resolving the whole problem of the patient. So in this case, obviously I give them some beta-histine and for nausea.
Carlos, I mean, our president has extended you the personal thanks,
Okay.
Dr. Narendra Suratwala and Dr. Pawan Singhal, who is our previous secretary just before me. And we also thank Dr. Prahlad, who is a very good help. And we have done around a dozen of webinars, and all of them were quite well attended. And I thank you very much personally for giving time and taking effort to convert your presentation from Spanish to English. I understand that it will be a little difficult for you, but and the model you constructed yourself, or it was a commercially available model? The model, the helmet model.
Okay. No, this model is with me. It's just for trying to understand. But no, as far as I know, it's not.
We can name it as Carlos Crown. You know, we can call it as Carlos Crown.
Carlos Crown. So I remember that in our country, Dr. Kurtne has one of kind of this model, and he used small balls to sew. But I think your model is quite a realistic kind of thing for especially the president and fellows.
Yeah.
Thank you, Prahlad sir.
I think we should invite Carlos sometime to India.
Yes.
Thank you.
Yeah.
Thank you very much to you. I really appreciate
Carlos. And his surgical neurotology is quite also is good at it. I know personally, and I mean, I think after the pandemic, you need to visit us.
And you know, we were blessed to have Dr. Santosh Kakkad sir today.
Okay.
He was listening to the whole thing.
Okay.
Okay, I didn't notice.
Yeah,
Oh,
I
sorry.
noticed that.
Yeah, okay.
Thank you,
Thank you
sir.
very
Thank
much.
you
Hello,
for
good night.
joining.
Welcome, sir.
Thank you.
Welcome,
Good
sir.
night.
Yeah.
Good night,
Good
all.
night.
Good
Good
night,
night.
all.
Good night.
That was a
everyone.
nice
Good day,
discussion.
Carlo.
Yeah.
Thank you very
Thank you,
much,
Dr.
Studio, for
Sreeram,
the
Dr.
invitation.
Sonali.
Wonderful
Thank you.
program.
Bye.
Okay.
Right.
Bye-bye.
Take care, all
Thank
of
you
you.
very much.
Yeah.
Bye.
Thank you, Dr. Pawan Boss.
Okay.
Thank you, Amit. Thank you.
Yeah.
Thank you.
Bye.